Okay, my next focus is not as much fun for me as the vascular surgery, but management of pediatric traumatic brain injury. Unfortunately, we see a lot of it, both accidental and non-accidental. And so I want to quickly talk about sort of defining major versus minor traumatic brain injury, understanding how Glasgow Coma Scale is different in kids, identifying what's low or high risk for minor head trauma in the kids that come in, and talk about who does and does not need a head CT on their presentation. So, defining TBI, as we all talk about and we all use, is the Glasgow Coma Scale, which started, of course, in Glasgow, Scotland, as a way to talk to higher care facilities as they're transferring patients. They would be sending patients to another hospital system, and they were trying, how do we describe how sick the patient is or how bad the traumatic brain injury is? And they came up with this scale, which has now become sort of universal around the world. And so mild, we define as GCS 13 to 15, moderate 9 to 12, and severe is a GCS of less than 9. So for a mild traumatic brain injury, again, GCS 13 to 15, can have a brief loss of consciousness, often have a little bit of nausea, vomiting, disoriented, and this is also consistent with a significant concussion. And so they've had a trauma-induced change in neurologic function, which is the definition of concussion, with plus or minus a mental status change or loss of consciousness. So it's really common in kids. In South Florida, very, very common. Across the US, about 500,000 emergency room visits a year for traumatic brain injury. 50,000, about 10% of those get admitted. And of those admitted, about 30% are less than 4. About 50% are in that 10 to 17 range. And it's the young kids that are the hardest to tell, because you can talk to the older kid, you can ask questions, you can assess GCS easier. But for the young kids, sometimes it's tough. And it's the most common, in the US, it's the most common cause of morbidity and mortality in kids. About 3,000 kids a year die from traumatic brain injury. About 5%, less than 5% of those admitted for TBI die. And no surprise to anyone, boys are about twice as likely to have a traumatic brain injury, because we just do dumb stuff. I have 3 boys, and I have made more emergency room visits with them than my daughter, proportionally by far. So there's also special attributes of the pediatric nervous system when we're looking at traumatic brain injury. I went too far. Okay. Infants have a very pliable, thin skull. There's a smaller subarachnoid space in kids. The infant brain, especially less than 2, is much softer. The immature myelination, more water content. They're much more susceptible to coup contra coup injuries, contusions. Their head's much bigger in proportion to their body. Also puts them at higher risk for some spine injuries. But one of the huge benefits is that they have a much better neuroplasticity than the adult population. So, and we still use the Glasgow Coma Scale in kids. There's a few differences though for infants, and these others are highlighted in yellow. So the infants obviously don't respond to commands, so opening up, so sounds gives them an E3. Appropriate for age, verbal response. Are they cooing, are they crying, are they normal? Are they really irritable and not crying at all, very restless and with lots of lethargy? So we use those as stand-ins for the normal adult criteria for GCS. Same with motor response, are they spontaneously moving versus obeying commands? And it's a subtlety, but it helps sort of us communicate within the trauma service for the infants for their GCS. And mechanism, to me, I've done this over the years, mechanism is the biggest thing I look at as someone is coming in and to evaluate the traumatic brain injury. Is it from a fall? Is it a short fall? Is it a very large fall? Were they in a motor vehicle accident? Were they struck by a car? Were they abused that we can tell? Was it a sports injury? And it helps us sort of triage as they're coming in for what we're looking for. And if we look at the data, the highest risk for mortality are age less than 4, having a low presenting GCS on arrival to the ED, either having a pre-morbid coagulopathy or a trauma-induced coagulopathy. Both are bad indicators for outcome. Hyperglycemia and hypotension. You know, the true incidence of the minor head injury is not really known because an awful lot of kids are never brought in. They bump their head, they fall, they get a fracture, parents keep it home, and they do okay. But for the ones that come in over 2, with a minor head injury in normal exam, about 3 to 7% of them have an intracranial injury. Less than 2, about 3 to 10%. Often no symptoms, but palpable scalp hematomas is an indicator that there may be something more inside. So clinical features of the minor head injury, only about 5%, less than 2, have a noticeable loss of consciousness versus about 13%. And those correlate with injury. Headache is about 45%, and vomiting is about 14% of kids who have significant injury or actually have injury will have vomiting. Seizures actually are not predictive at all. The traumatic seizure upon impact, not predictive of having a really bad intracranial injury. So the types of brain injury that we tend to see in these kids who come in with minor injury is cerebral contusions from coup contra coup, the brain bouncing back and forth and having the sort of more water content and less myelination. The kids are a little more prone to it. They get the traumatic subarachnoid hemorrhage with it. And then this is the one that the focal injuries of an epidural hematoma. This is sort of the loose interval silent killer that I've seen quite a few times. Kids come in with a minor epidural with a fracture in the right location, and we're always getting a repeat head CT within 6 hours, because that's sort of the time frame in which they'll decline if they're going to decline. Liam Neeson's wife, the actor, she died of an epidural, seen in a hospital, was doing just fine, sent home after having a skiing accident, and then six hours later died when the epidural expanded. And usually the epidurals involve a fracture and they lacerate the middle meningeal artery. But they're wonderful to treat if you catch them in time, because they always do well. If you get it in time, take out the epidural, the brain usually is not injured much underneath, the kids do great. Subdurals are a reflection that there's been usually a broader injury. There's tearing of the bridging veins, often significant brain injury, and they cover more of the whole hemisphere, and usually quite a bit of significant shift. Still can do well, but there's often a sign of more intracranial injury. And the traumatic subarachnoid hemorrhage, sort of with the coup contra coup or just independent traumatic subarachnoid hemorrhage, very different in pattern than aneurysmal hemorrhage. It's over the surface, it's small, and then we have diffuse axonal injury, the most severe form of diffuse brain injury, and often not seen on the CT scan. Here's an example of traumatic subarachnoid hemorrhage. I'm going to hurry a little bit, I'm behind time. And this is an example of shear injury. On this one, we could see it on CT scan, and then the corroborated on, you see it even more prominent on the MRI with MRI findings. And so if there's, sometimes we'll see someone who looks like a minor injury on head CT, but Glasgow Coma Scale is really, really down, we will get a MRI to take a look for shear injury. Because if we don't see mass effect, we don't see compression, we don't see a focal lesion, but they may have just had sort of the shear injury at their gray-white matter interface. So in the past, a lot of the kids who would come in would be evaluated with skull radiographs. Very rarely happens anymore. If there's any concern, everyone seems to go directly to a head CT now. But it used to be sort of the protocol for a kid had a scalp hematoma, and you can see the little parietal fracture there on the left. Most of them that we see, and I see at least 3 to 4 a week come in with linear skull fractures. Fell off the bed, dropped by parents, other things. I always see them back in a month after we see them, for the small risk that I've seen quite a few growing skull fractures where the linear fracture shears the dura enough for a CSF leak, and then the fracture doesn't heal, and it just gets kind of bigger and bigger over time. And those require operative intervention. So if it's healing and we feel it healing in a month, we don't have a risk of that. So I check all the kids a month out, make sure that it's healing okay just by palpation. Depressed skull fracture, if it's open, dirty, we have to wash it out and repair it. If it's the infant variant of the ping pong fracture, we often can just observe. Okay. So these are 2 examples of a ping pong fracture. They're on the left on the skull x-ray, and they're on the 3D reconstruction. And so in my training, we elevated a lot of these. We put in just do a small incision, little burr hole, stick a number 3 Penfield underneath it, and just pop it up. Very simple surgery, very effective. But the corollary is I have a lot of parents who didn't want surgery, and so I followed some of these kids, and almost all of them will pop up by 6 months to a year. If they're happening at that 3 to 4 month range, most of these, the surgery to fix it's super simple, but most of them could just be observed and it will correct on its own. The skull is still thin and pliable enough that give it 6 months or a year, it'll come up. Basilar skull fractures, these usually have a significant mechanism to create a fracture through the skull base. About 5% of skull fractures in kids are this. Not uncommon to have a CSF leak. Cranial nerve deficits are common. And this is an example of a 4-year-old who came in with a TV that had fallen on her head off a dresser. Crushing injury, pretty big TV. Sent home, did well, had no issues after the fracture, but did see a basilar skull fracture. Came back 2 weeks later, obtunded with a high fever. And she had gotten staph epi from the CSF leak and had a huge infection that we had to wash out. Yeah. It looked like an egg yolk, but smelled a lot different. So for evaluation, we always scan severe TBI, GCS less than 8. Moderate gets a head CT. For mild traumatic brain injury, it really depends. It's become really common in the pediatric population to scan all the kids who came in. Like nationally, they quoted 13 to 20%. In my institution, 50 to 75% of kids who came in with a head bonk got a CT scan. And it's a theoretical risk, but there is a risk of eventual cancer in the pediatric population. So we sort of have been addressing that in my hospital system, looking at mechanism, looking at the findings of deficit, loss of consciousness, trying to minimize head CTs on kids that just don't need them. And so I'm almost out, so I will go fast. But non-severe mechanism, no loss of consciousness, no vomiting, we will just observe these kids and not scan most of them in an attempt to save them from radiation unless we see a change. So for our disposition for the minor head trauma, if no focal lesion, no bleed, just a skull fracture with no underlying traumatic subarachnoid hemorrhage or subdural, we let them go home from the emergency room after some observation and follow up with a pediatrician, and I'll check them in a month. With minor traumatic subarachnoid hemorrhage, subdural, we watch overnight in the hospital, and then they will see me in a month again to make sure things are healing okay. If it's more concerning, if it looks like an epidural, if there's a fracture around the middle meningeal, then we will repeat the head CT. Now, one thing we have to do, that's become part of the state of Florida and part of just what we do in medical practice now, is that especially if they're less than 6 months, they all get a workup for non-accidental trauma. It's unfortunately way too common in our population, all the people we see. And we see a lot of kids that come in with a skull fracture that have healing femur fractures, old rib fractures, other things. And so all these kids will get, if they're less than 6 months, will get an abuse workup as well. For the moderate traumatic brain injury, we will repeat CT if we find significant findings. If not, we watch their neuro exam. We get an MRI if we have to worry about diffuse accidental injury. And we try to avoid intubation. Try to follow their exam so we don't have to put a monitor in. If they're less than 8 with a significant injury or signs of swelling, they all get a monitor. Again, no studies have shown long-term improved outcome, but it gives us a target to treat. It's our standard of care. And it gives us a target for therapy so we can monitor things better. We use sodium and not mannitol for management of most of these patients. Hyperventilation is only during acute phase for rushing to the OR. It used to be a chronic way to treat, but we only do it now if we are going directly to scan or directly to OR. Standard things, keep head of the bed up, maintain euvolemia, put an ICP monitor in, 3% sodium. We will do a paralyzation or barbiturates if we can't control it. And we do a decompressive hemicranie early, especially in kids. If there's any signs of increased ICP, focal lesion, they get a decompressive hemicraniectomy. Okay. This is just an example of the decompressive hemicraniectomy. I try to make it at least 15 centimeters AP diameter to make sure we've decompressed enough. The cartoon here doesn't show it well enough, but I always like to make sure I get enough of temporal decompression. So we remove compression on the temporal lobe and uncal herniation. I think that does make a big difference. And I just put in a dural replacement and then close the skin. Again, big compression. This is a 3D recon of it. Give the brain room to swell. And just for the long-term outcome, so we've done a decompressive hemicraniectomy. The kids survive. We've done okay. I try to put it back in 4 to 6 weeks, especially for the young kids, as their brain and their skull keeps growing. And I've had some, when they're like 2 years old and you put it back too long, it no longer fits. Their whole skull has changed. So I try to, if the brain swelling's come down fast enough, I try to put it back in 4 to 6 weeks. If we can't use their bone or their bone's comminuted, we use polyethyl ether ketone, custom-made bone flap from their CT scan. And then if that doesn't work, like this was a 14-year-old kid who had an ATV accident, comminuted skull, was thrown away. So we did a PEEK implant. He didn't tolerate it, eroded through. So eventually we had to reconstruct his skull just from splitting his ribs. So we just took 5 ribs, split them in half, and then used that to reconstruct his skull. And then it grew in as one solid mass. So that sort of is a fail-safe. If you can't repair it another way, the rib method actually works really, really well. So again, my cell and email, global health information, and any questions. Thank you.